Hi, everyone. This is Dr. Beebe. I'm here to kind of summarize and go through chapter 6. Now, I will warn you, chapter 6 is a very large chapter, okay? It talks about all the study design. So I'm going to cover the highlight, but like I said, it's a very long chapter. So, give yourself time to go through this this week. All right, you can read the objectives. So we're going to go through these different designs. So in last chapter, we talked about the fact that there were different types of study designs: exploratory, descriptive, and analytical. Okay. Remember, exploratory and descriptive were helpful as far as generating hypotheses, and the analytic design allowed us to test hypotheses. Okay. So with all these study designs, they all have strengths and weaknesses. None is perfect. And it's important to understand what the strengths and weaknesses of each type of study design is, so that when you are designing it, you can kind of answer some of those strengths, answer some of those weaknesses, and so that you end up with the best study design that will work for you. Each study design is observational except for the experimental study design. And the experimental study design is considered the gold standard of experimental designs. It's when we have an experimental group and a control group, and where we are intervening or we are manipulating the participants in some way. So the first one we're going to talk about is a case study, and case studies sometimes get a bad rap. And the reason I say this is because a case study is usually a very in-depth study of one individual or one patient. So case studies are what allows us to originally define or describe a problem or health issue fully. So these are incredibly important, because if a physician comes upon someone who has signs or symptoms that are new to him, or they don't fit the mold of everything that he knows about, then he can do this in-depth discovery of this individual and create this entire case study file that then, if another physician comes across an individual with very similar signs or symptoms, then we can start to define this health issue and see if it's something completely new. So they have a very important role. But like I said, they tend to not get the respect that they deserve, because they're not these large studies that we think of, with 3,000, 4,000 people. A case report, like I said, involves a profile of a single individual. However, a case series is a group of these individuals. So these groups of individuals with similar diagnoses. Ecologic study. Okay. So here we're looking at information on the group level, not on the individual level. So this is something very different than what we were just talking about with a case study. Okay. So these types of studies are going to show the prevalence or risk factor, potential risk factor, compared with the rate of the health issue or outcome that we're looking at. Okay. Some strengths of this is it does frequently take advantage of pre-existing data. These can be relatively quick and inexpensive. And once again, when we talk about cross-sectional or survey experiments a little bit later, that's also something that's kind of quick and cheap. Okay. However, it is susceptible to confounding. Okay, because we are looking at this data and it's not measured on the same individuals. What distinguishes it, once again, is its aggregated data on the population level. And one issue is what's called ecologic fallacy, in which we make conclusions that are stating that the association, if it exists on the aggregate level or the population level, that it's also true on the individual level. Okay. There are three types of ecologic studies. We can do a cross-sectional ecologic study, which compares aggregate exposures and outcome data at the same time, so one point in time. We can look at like time trend ecologic study, where we're looking at time or change over time. And then we can look at something that's just solely descriptive in nature, in which we're looking or exploring the differences in risk factors or health outcome between the populations at the same time or within a given population over time. Okay, so this is an example of the incidence of melanoma of the skin in the United States. Okay, and you can see this is by sex and time, or by gender and time. A cross-sectional study is where we are looking at the variables at one point in time. Okay, just one point in time. There's no distinction made between potential risk factors or outcomes. But like I said, it's a very efficient way to collect data. It's very good at giving us prevalence. Okay, and remember, prevalence is the number of new cases plus old cases. So a survey is wonderful. A cross-sectional study, which frequently is a survey, is a wonderful way to collect a lot of data, but only for a single point in time. So it doesn't allow us to kind of get any causal relationship, okay, because it's just this one point in time. All right. It is quick, it is easy, it is cheap. We can, with a click of our mouse, can send out a survey to, 14,000 students within a university if we want to. Okay, so it's very easy and very quick. Okay. So some of the strengths, it gives us control over the study population, over the measurements. We can look at prevalence. Some weaknesses, we really don't have any kind of time relationship. So, and what I mean by that is we don't have any time relationship between exposure to the risk factor and outcome of the variables. So, we don't know, had they not been using sunscreen for, a year or 2 years or 3 years or never, and when did the skin cancer, when was that diagnosed? So we have no kind of idea of that time relationship. And once again, there's really no kind of causal relationship here. It's really just association. These are going to be run over a short period of time, usually a few days or weeks, and there's no follow-up. And that's another weakness, is we have no way to follow up with these individuals to get any sort of clarification. I think we've mentioned a lot of these, but some of the strengths, we can study several associations at once, meaning we can list many different risk factors in one survey, so we can see how many people have been exposed to certain risk. Very quick time, short period of time to get these out and get these back. So we're not looking at a longitudinal study where we're following these individuals over years. Great for prevalence data. Okay. There is some bias as far as recall, as far as remembering correct responses, and we can't follow up. So it's not something that we can, we can ask for clarification. Weaknesses, influenced by response bias, not good for looking at very rare conditions. And we kind of lose that time and exposure relationship, or that sequence of events. Serial studies are cross-sectional surveys that are longitudinal. So these are things that are routinely conducted. So the US Census is a great example of this. The Behavior Risk Factor Surveillance System. These are all examples of serial surveys, okay? And this is data. This is the type of data that can be produced with these kind of serial studies. Next, we have the case control study. Okay. In this, we're looking at the presence of an exposure and how it's compared to between cases and controls. Okay. So this is very effective for rare outcomes, which we were just looking at the cross-sectional, which wasn't. Okay. A weakness is it's limited to just one outcome condition, so it doesn't give us precedence, or I'm sorry, incidence. It doesn't tell us relative risk or natural history of the health issue. Okay, it's less effective than a cohort study, which we're going to talk about in a minute, as far as kind of helping us establish that time relationship of events or that time sequence. So a case control study, retro, basically means to look back. All right, so we will identify cases. So these are going to be people that are experiencing the health-related state or issue that we're talking about. And then we will identify controls, so people who are not experiencing the health issue. And then we're going to survey or interview these individuals and see what they've been exposed to. And then we'll look at that research or that data that comes in and says, and say, oh, well, in the cases group, 85% of them reported living close to a power lines. Okay. While in the control group, only 5% reported living next to a power line. So maybe when we're looking at, maybe the health issue is Alzheimer's, so we were looking at the cases, which were individuals that have Alzheimer's, and the controls are people that don't have Alzheimer's. Well, maybe living next to a electric wire, because that was 85% in the cases group, maybe that's a risk factor then for Alzheimer's. Okay, so we're looking back, it's retro. We're asking individuals to look back and respond to questions about their past experiences, risk factors, and lifestyle behaviors. Okay, so this is more information about the case control study. It's very important that we define the disease, okay, so that we're certain that who we have in the cases group are actually individuals that meet our definition of the disease or our diagnostic criteria. So that will help us select the individuals to be in the cases group. Okay, and we want those cases to be representative of all persons with the disease. Okay, so we don't want outliers that might have conflicting health issues or do not fall within our definition. As far as sampling, we do want random selection, and we hope for a relatively large sample size. Okay. And then our control subjects should look very much like our case subjects, except for the fact that they do not have the disease. So we want them to be similar age. We'd want them to be from similar backgrounds. We want to get rid of any kind of confounding variables so that the biggest difference, or the only hopefully difference between the two groups, are one have the disease, the case group has the disease, and the controls do not. Okay. There are 3 types of special groups of populations that sometimes are used for this. Sometimes hospital groups or hospital controls are used. Some of the advantages of that are they're easily identified, low cost. But a disadvantage is that they usually differ from healthy people. So they don't accurately represent the exposure distribution that we're looking for versus the general population. Okay. which they will represent the population from which the cases were selected, but much more costly, much more time consuming than hospital controls. And then, of course, we have special groups such as family, relatives, or friends are going to tend to be healthier than the hospital controls. Um, And then, of course, also within the case control study, we have to be aware of exposure status. And we can frequently obtain that information through medical records, interviews, questionnaires. If we're looking at our original example where we had our case group were individuals that met the diagnostic criteria for Alzheimer's, maybe we have surrogates such as their spouses or siblings that answer those questions for us. We have the case crossover study, excuse me. This we are looking at frequency during a window immediately prior to the outcome event. Okay. One of the strengths of this is it controls for fixed individual characteristics that may otherwise confound the association. These are effective if we're looking at short-term exposures. However, they don't automatically control for confounding from time-related factors. Okay, so we are comparing kind of the exposure status of a case immediately before its occurrence with that of the same case at a prior time. Another example of a case control study is a nested case control, okay, in which the controls are time matched to the cases. So this is another version of a case control study. And basically all it is it's nested within the cohort study. So we're matching these up based on timing. A cohort study is our next one, okay? This is if we follow a group over time to describe the incidence or the natural history of a condition. So for something like this, we actually will have a group of individuals and we will follow them over years. So we might have them and ask the same group, give the survey to the same group of people, then give it to them a year later, then give it to them a year later, give it to them a year later. And what we're doing is we're measuring their exposure to certain risk factors. And we are measuring the incidence of new health issues or health outcomes. Okay, so this is very strong as far as it gives us that time sequence of events that we were missing in the case control studies. Okay, this gives us this because we are actually following these individuals over long periods of time. Okay, what some of the weaknesses of this kind of prospective approach is that we usually need large samples. This is a very expensive and time-consuming type of study because we need someone that's going to follow this same group of people over time. And we also have a lot of attrition rate. We lose a lot of people. People move, they don't give us forwarding addresses. People get tired of filling it out. So, sometimes we have that loss of follow-up with these larger studies, but it's a tremendous, tremendous amount of information that we can get from this. Okay, so usually in epidemiology, we're looking at groups of individuals who were born like in the same period or the same year. And then we're going to follow these individuals, hopefully, over large successive time periods of life. So as the group ages, we can actually follow their changes over time, follow what they've been exposed to, follow what new health conditions they develop, and collect kind of these vital statistics of the group. Some examples. Um, your textbook talks about looking at the mortality from breast cancer in a cohort of 31,710 women who had been treated for tuberculosis at the Canadian sanatoriums between 1930 and 1952. And it showed that the risk was greatest among women who had been exposed to radiation when they were between 10 and 14 years of age. Okay. And with increasing age at first exposure, there was a substantially less excess risk, and the radiation effect appeared to peak approximately 25 to 34 years after the first exposure. So all of this information you could not get any other way, but in this sort of prospective cohort study. Okay. I've already mentioned this, the fact that we're looking kind of that change in health status, variation in disease according to what they have been exposed to throughout this time. And it's also very interesting because some of these studies can look at societal changes and kind of social status too, and how that affects access to healthcare. Okay. And cohort studies can be prospective or retrospective. Prospective, once again, looking forward. So we're looking at these variables before the health outcome has occurred versus retrospective, in which we are looking backwards. So we know the health outcomes. So we are collecting data from this predictor variables or the risk factors. Okay. And then these are the charts in your book, kind of summarizing prospective versus retrospective cohort designs. They also talk about double cohorts. Double cohorts are very important if the exposure is rare, and we're looking at relatively small numbers of people that are impacted by the health outcome or health issue. Okay. This is a case cohort study. Okay, and this is the summary from your textbook. This is an alternative to the nested case control study design that we looked at before. So we're looking at randomly sampled subcohorts and all cases. So basically, in a case cohort study, we start with a cohort. And from that parent cohort, we randomly select a subcohort at the start of follow-up. And this subcohort may include some cases. And then we include all cases that occur outside of the subcohort during follow-up. Okay. So the big difference between this and the nested case control study that we talked about before is how these controls are selected. Okay. And then lastly, we have the experimental study. Now, once again, the experimental study is considered the kind of gold standard, if you will. For this, we have to have a control group. We have to have an experimental group. We always have an intervention. So we are manipulating something, which is what we call our independent variable. So whether that independent variable is a medication, whether that independent variable is a certain type of surgery or therapy. It's something that we're exposing the experimental group to and measuring the results of. Okay. I'm sorry, I want to go back here and just talk about a couple things. The strengths of this are that this does allow us to start to explore a causal relationship. Okay. We can design this to kind of avoid as much confounding variables as possible so that what we're measuring is actually a result of our intervention. Okay. And it usually is going to be faster than the observational studies that we've already been talking about. Now, some of the weaknesses are that, yes, it starts to help us with the causal relationship, but in humans, there's a lot of barriers, ethical barriers to experimental design for certain research questions with humans. So if it's something that's harmful, so if we're looking at the effects of recreational drugs or the effects of psychological drugs on individuals, we can't lock individuals up in a room and expose them to chemicals that we believe that will cause lasting damage. Okay, because ethically that would be not allowed. Okay, totally inappropriate. So we have to be very careful because we can't design experimental designs or experimental studies for every question that we have. Okay, so we have to come up with other ways to do this so that we aren't causing harm for the subjects. Okay, and you can read these examples from the textbook. And once again, like I said, this is the best for establishing causal relationships. We can also use it to evaluate the efficacy of prevention and therapeutic interventions, so vaccines, medications. Like I said previously, there's an intervention in experimental studies, so there's something that we are manipulating as the experimenters ourselves. Between groups design is probably the strongest variation of this design. So if we are looking at dosages of medication, perhaps, so we'll have more than one group, more than one experimental group. So the control group would be getting a placebo. They would not be getting the actual medication, while experimental group 1 might be getting 100 milligrams of the medication, while experimental group 2 might be getting 2 doses of 100 milligrams, okay? So this is a between groups design. The controlled trial, now remember, we're looking on individual levels. We're not talking about population levels. And this is in a clinical setting, so it's referred to as a clinical trial, versus a community trial in which the unit of analysis is at the group or community level. Not as common. We also have what's called a natural experiment, in which the levels of exposure to a presumed cause differ among a population in a way that's relatively unaffected by extraneous factors, such that the situation resembles a planned experiment. So an example of that is in Seattle, in the Puget Sound area. They were screening and treating for prostate cancer, and that differed considerably from that in Connecticut during 1987 and 1990. Okay, so they were looking at the PSA testing of Seattle versus that of Connecticut, and the rates in Seattle were 2.2 times higher than that in Connecticut. So this was a natural experiment in which that it came up from this PSA testing. Okay. And you can read the rest of that. We also can have within group design. Okay. So the between group design is what I described a minute ago, where we were talking about the different levels. Okay, so we were looking at one experimental group getting 100 milligrams, while the other experimental group got 2 doses of 100 milligrams for a total of 200 milligrams. Okay. However, within groups design, is when we are testing groups prior to the intervention and after the intervention. So sometimes we might be looking at an intervention that might cause stress. So we might want to test or test stress levels in individuals prior to the intervention, and then test the stress levels after the intervention, so we can look at the change from the intervention. Okay, so that's a within group design. All right. Random assignment. So we talked a little bit about kind of trying to control the confounding variables so that what we see is actually going to be a result of what we are intervening with, or whatever risk factor that we're talking about. Random assignment is one of those ways that we can kind of control the outcome or control what we're measuring in an experiment, because its goal is to make certain that we are not purposely putting individuals in one group versus another, so that the only reason that they're winding up in the control group versus the experimental or intervention group is completely by chance. Okay, and this allows us to kind of balance out these confounding variables if our number of people in the study is sufficiently large. So if we have a sufficiently large number, if we can add some blinding, which we're going to talk about in a minute, and if we're using random assignment, we have a greater likelihood of what we're measuring actually being a result of what we're doing. Okay. Sometimes we have non-randomized studies. Okay. Some of the problems with this, once again, is it's not going to be useful or effective at controlling these confounding variables that we've been talking about. However, at times we can kind of account for that with certain statistical methods. All right. I want to talk about blinding, because blinding is something that most people have heard of, but there's different levels of blinding. So the single blinding is when the subjects do not know which group they're in. Okay, so if we have the individuals that are taking that medication that I talked about, we have our control group, which is getting a placebo. So if my medication is a red capsule, then I'm making a red capsule that has something inert like sugar or something in it, but it looks exactly the same. So neither the people in the control group or the experimental group know which of them are getting the actual medication. All they know is that both of them are getting a red pill. Okay, so that's single blinding. Blinding the subjects so they don't know what group they're in. Double blinding is if the investigators that are actually handing out the pills and handing out the instructions don't know which group that they're talking to. They don't know which group is which. Okay, all they know is that they're handing out red capsules with the same instructions to both groups. Okay, they don't know which group has the sugar pills and which has the actual medication. And this is important because people can tend to, without even thinking about it, you might talk to the control group and say, okay, make sure you take this red capsule at 8 a.m. in the morning, make sure you take it with 8 ounces of water. Okay. And then they might go into the experimental group and say something like, make sure you take this red capsule at 8 a.m. in the morning. Be very certain to drink a full 8 ounces of water with with this medication. It's very important that you get that full 8 ounces. Okay. So they might emphasize things a little bit more. And once again, they're not doing it on purpose. They're not necessarily trying to lead or influence the subjects. But if they know which is which, they want to be certain that if they know that this new medication has to be taken with exactly 8 ounces of water, they might emphasize that more with the group that they know is getting the medication versus the ones that are just getting the sugar pill. So by having double blind, we can get rid of that kind of accident that might happen. And then a triple blind is if the subjects don't know, investigators don't know, and the analysts don't know. Okay. And that's important because once again, the analysts, we don't want them to round up or round down because they know what they want to get. So they're just getting data. They have no idea if the data is coming from the experimental group or the control group. Okay. So then we can assure that they are doing the statistics exactly the same way without any sort of bias. Okay. And so this is just explaining each of those prospects that I just got done talking about. Single blind, double blind, and triple blind. Okay. All right. And once again, I've already explained all this. I got ahead of myself. And this is just talking about the placebo. Once again, we want to make sure it's a pill of the same size, color, shape, or as the actual medication. There even are things such as sham operations where they put the individuals under anesthesia and actually have an incision so that they are coming out and walking out. And if they happen to communicate or come across someone in the other group, they have the same experience, excuse me. Okay. And this last slide is also actually just saying everything that I've already said. Once again, I get ahead of myself. Okay. As far as problems with binding, in some studies that are non-drug, they involve behavioral changes or surgery, so it might be unethical to blind. Okay. And sometimes there's also studies that have medications that have very characteristic side effects. So these side effects might be something that, in the experimental group we're going to see, but if they come across someone in the control group that doesn't have those same side effects, they might be able to figure out which individual has the experimental group and which one is in the control group. As far as the purpose of experimental studies, we are looking at kind of identifying clinical and public health approaches to solving public health problems. Okay. And you can read about these blinded random controlled clinic trials. All right. As far as a randomized controlled trial, okay, there's steps that are involved. So the first one is the intervention. The first one is we have to select the intervention. So whether we're talking about an intervention that is a medication or an intervention that is a new therapy, we have to select the intervention. Then we have to get the study cohort together. Okay, so we have to figure out what are going to be our inclusion or exclusion variables. What's that criteria? We have to measure our baseline variables. We have to choose our comparison group. Remember, we're going to want to make certain that that group is as close as possible. We're going to ensure compliance, and whether that compliance is in the testing or the application of the intervention. And then we're going to select what is our endpoint? What is the outcome that we're looking at? Okay. So when we're selecting the intervention, obviously we have to know what is our research objective? What are our questions? Where are we trying to get? Okay. Are these going to be safe and active against the disease? Is there evidence that one therapy is better than another? And then a phase 1 trial is an unblinded, uncontrolled study with typically fewer than 30 patients. Okay, now here we're talking about kind of the phase 1 drug and device trials. Okay, so basically in these, our main job is to determine the safety and potential use in humans. Okay, typically the individuals in this group, because we are still determining safety, um, often have advanced disease and are already and have already tried other options. Okay. There's very, very close, intense monitoring during these phase 1. And drugs that actually show promise, or drugs or devices that show promise, advance to phase 2. Okay. Phase 2 is still going to be relatively small. So we're looking at 25 to 100 individuals. Okay. Uh, and for this, obviously, we're going to use random assignment and blinding. And we're looking at different dosages. Okay, so they might be given different dosages in different ways to determine what's the best way to balance kind of the safety and effectiveness. There's special focus on tolerance, once again, the safe dosage, and side effects. And if and only if there's good evidence that this new treatment is at least as good as existing treatments, then we can move on to phase 3 trials. Okay. Phase 3 are much larger. Now we're moving up to numbers in the thousands. Typically, these are also going to have random assignment, and we're looking to kind of evaluate the efficacy of this new treatment. Phase 4 may or may not involve random assignment. These are very, very large studies. They occur after the therapy has been approved by the FDA, and we're looking to assess the rate of serious side effects and to explore further therapeutic uses. Okay. So now this is going through these other steps. So assembling the study cohort, once again, we are going to look at inclusion criteria, broad versus specific. All right. We also define the exclusion criteria. Okay, and once again, this is to help control error. And also sometimes to exclude those who might not stay in compliance. Individuals that might have a hard time remaining in compliance during the study. And then, of course, look at sample size. We measure those baseline variables, so kind of the characterization, the demographics like age, race, gender. Okay. So this is an example of certain demographic variables that you frequently see in studies. We're also going to look at various predictors or risk factors of outcomes, okay, to make certain that we can allow for kind of statistical adjustment of these types of things. Remember, we have to select the comparison group. We want it to be as close to the experimental group as possible, so that the only thing that it's not, that they don't have in common, is the treatment. We typically prefer to blind, and this would also include using a placebo. To ensure compliance, we want to make certain that we are being complete in our directions. We want to send reminders out, call prior to the clinical visit. Reimbursement is always a useful way to ensure or to encourage compliance. And we want to try to keep it as simple as possible so that they can adhere to the intervention protocol. So if there's a way, like taking one pill a day versus a very complex sample of taking 2 pills in the morning, 1 pill at lunchtime, 1 pill at 3 o'clock, and then 2 pills at bedtime, So making it something that's easier to follow, and it's going to have a higher likelihood of compliance. Okay. And then, of course, selecting the outcome, our primary endpoint. Okay. A pilot study is kind of a test. Okay, it's a test before a larger study. Usually, a pilot study is very helpful, like for grant funding, because it's kind of a dry run, a small test of what we're proposing on a larger scale. And you can read about basic randomized designs versus run-in designs versus factorial designs, match pairs, and group randomization. Okay, so I'm not going to go through all these. You can read through these. I do want to touch on ethical principles. We want to maximize good, avoid harm. Okay, and that's kind of the bottom line. We want to have respect for all persons. We want to make sure that it's fair to all. We want to make sure that everyone understands exactly what's involved with this study, so that they can give consent. Okay. And, is it important for us to tell them that there's a likelihood that they won't be in the experimental group? Okay. We have to think about, is it right to compensate them for injury? Who should be permitted or encouraged to participate and who shouldn't? Okay. We need to make certain that they know that they can opt out at any time. But we also have to make certain that if they do want to opt out, make sure that they're doing it in a safe way. So if they were on a medication trial and they're having adverse effects from the medication, how does that have to stop? Do they have to be weaned off, or is it something that, won't hurt them to be abrupt, or it's better for it to be abrupt? Okay. A very good example of the importance of ethics is the Tuskegee syphilis study. At the time they did have a treatment for syphilis, they were actually using this to observe the natural history of syphilis. No treatment was offered for the syphilis. No new drugs were tested. They actually were just observing how the syphilis affected the individuals. It was a very unethical tragedy that happened in experimental design. Okay. And then, of course, this is the summary of the chapter. And like I said, once again, this was an incredibly long chapter. But I hope this was helpful to you to talk through it. And just take your time. The chapter is actually not that hard to read through. But once again, like I said, it's just very long with a lot of content. All right. Thank you very much. Talk to you soon. Bye-bye.